Hello everyone, welcome to Patho Excellence. In this lymph node cytology series, in previous videos, we have discussed lymph node histology, lymph node cytology and age related as well as regional lymphadenopathy with its different causes. So, because of this wide differential diagnosis ranging from infection, lymphoma and metastasis, a rapid, minimal, invasive and reliable diagnostic technique becomes extremely important, which is FNAC. So, this is where lymph node fine needle aspiration cytology plays a crucial role, right? So, accurate diagnosis does not depend only microscopic examination. It actually begins much earlier with proper clinical evaluation, correct aspiration technique, appropriate smear preparation and optimal staining methods. So in today's session, we will systematically discuss prerequisites before performing lymph node FNAC, step-by-step aspiration technique, different smear preparation methods and staining techniques, and most important, how to perform an overall assessment of the aspirate using key diagnostic cytologic clues, in which it includes core criteria for adequacy, cross examination of smear, cellularity, some major cause of misdiagnosis like artifacts, background assessment, cellular aggregates, and cell size and monotony. Right? So before we evaluate fine needle aspiration smears, we have to answer some questions sequentially. Like first is the aspirate adequate? Is the nodule clinically considered to be a lymph node really a lymph node? Is the lymphadenopathy caused by a benign or malignant process? If it is benign, whether it is infectious or can be infectious agent be identified? If it is malignant, is it a metastasis or lymphoma? And if it is a metastasis, what is the type? Carcinoma, melanoma, sarcoma, or where did it most likely originate? And if it is lymphoma, whether it is or non-Hodgkin's or Hodgkin's lymphoma. If it is non-Hodgkin's, is it of B or T type? What is the subtype? Is it possible to grade it? And if it is Hodgkin's lymphoma, is it possible to determine the subtype? So, these are the questions we have to keep in mind and we have to answer it sequentially. So, before that, we have to prepare a mindset which is called the diagnostic mindset in lymph node FNAC, which is having three hierarchical tiers. So, tier 1 means technical and representational. So, in this, we have to see whether it is a sample is adequate or not and whether it is truly lymph node or not. Second is pattern recognition. So, in which what is the low power pattern? Whether it is reactive, infectious, metastatic or lymphomatous. And in tier 3, lineage and subclassification. So, if lymphoma, whether it is NHL or HL, NHL, B or T, subtype, grade, and if it is metastasis, carcinoma, melanoma, sarcoma, primary site. So, this will help you to narrow down your diagnosis when you start your microscopy. So, these are the prerequisite clinical history before you perform FNAC. So, these history points include, first of all, duration of lymph node enlargement. So, always ask history about the duration because acute most common is in infectious causes, chronic we have to rule out TB, lymphoma as well as metastasis. Now, pain history, if painful, mainly in inflammatory lesions, painless, lymphoma or metastasis. Constitutional symptoms, which is also called B symptoms, which is fever, night sweats, weight loss, and it suggests lymphoma or tuberculosis. Now, past infectious history or past history related to tuberculosis, viral infection, HIV, any previous malignancy to rule out metastasis, medicine history like phenytoin or immunosuppressive drugs, and this is the table. It is having so many drugs which can cause lymphadenopathy, and we have to also ask about travel exposure history for any tuberculosis or zoonotic infections, and do not forget to ask for any habits related to smoking, tobacco, alcohol to rule out any malignancy or metastasis. Next is, before FNAC, basic laboratory investigations are also important. In hematological test, we require CBC and peripheral smear to see whether patient may have leukemia, infectious mononucleosis or reactive lymphocytosis. Infection screening tests like ESR, MON2 test, HIV test or serology for Epstein-Barr virus and cytomegalovirus. Imaging is very important. USG guide, ultrasound lymph node, chest X-ray, CT scan if required to identify deep nodes, any primary tumors, whether patient is having any lung tuberculosis or any number of lymph nodes, sites of lymph nodes. So all these helpful in our diagnosis. And some microbiological test if infection is suspected, like AB staining, gene expert for tuberculosis and fungal stains. So here in this table, these are the clues and initial testing to determine cause of lymphadenopathy. Like if patient is having fever, night sweats, weight loss, like these symptoms, we have to rule out leukemia, lymphoma, any tumor or metastasis. So we have to go for CBC and biopsy or bone marrow biopsy, ultrasound. So it will help us for narrow down our diagnosis. Same like fever, chills, sore throat, nausea, vomiting, diarrhea to rule out any infection. At that time, we have to ask for some CBC monospot test or LFT culture to rule out infection. High risk sexual behavior like chancroid, HIV, lymphogranuloma, venerum, and syphilis, we have to go for HIV, HIV-2 immunoassay, rapid plasma reagent culture, and nucleic acid amplification for chlamydia, etc. Contact history with animal or food contact, rabbit or sheep, cattle, wool, hair, and hyzo. All these are like cat scratch disease, toxoplasmosis, anthrax, brucellosis. So these are the disease in which the Center for Disease Control guideline we have to see, and we have to go for serology and PCR test. Recent travel, insect bite based on endemic region, and serology and testing is required in suspected exposure. If patient is having arthralgia, rash, joint stiffness, fever, chills, muscle weakness along with lymphadenopathy, to diagnose rheumatoid arthritis, Sjogren syndrome or dermatomyositis or SLE, so we require ANA or anti-double strand DNA, erythrocyte sedimentation rate, CBC, RA factor, creatine kinase, or muscle biopsy if indicated. So these are some prerequisite history as well as basic investigations to rule out causes of different types of lymphadenopathy. Now, how clinical examination of lymph node is important, like if size and number, if it is more than 1 centimeter or multiple, bilateral, it is usually significant. Consistency, if it is hard in consistency, suggest mostly metastasis. Matted lymph nodes, which is for tuberculosis, rubbery nodes are more common in lymphoma. Tenderness is mostly in cases of infection, and mobility where fixed nodes suggest malignancy. How to palpate a lymph node? So technique is use your finger pads, mostly index and middle finger. Roll node gently against underlying tissue. Compare both the sides and evaluate size, surface. See the tenderness. Palpate to see consistency and check mobility. So now how you compare consistency? So this is for during palpation. If soft, we have to compare like it's a earlobe or lip uh, uh, softness. So it's suggestive of reactive or any infection. Now how to check whether it is firm or rubbery? So you check the consistency with the tip of nose. It is firm in nature. So if you feel that type of firmness, mostly it is a lymphoma or chronic infection. Now how hard it is? Like forehead bone, it suggests metastasis. So soft like lip, infection, rubbery like nose, lymphoma, and hard like forehead, it is metastasis. Now FNAC with aspiration, in which site should be cleaned with the spirit swab, and needle is introduced in swelling and gently moving to and fro, and simultaneously negative suction is also created by withdrawing the piston. You can also do FNAC without piston, and when you aspirate the material, needle should be removed and smear is made by gently pressing the upper slide on the lower one, and air is taken in the syringe and needle is reattached to expel all the material. So this is a technique for FNAC, but if you want to perform USG guided FNAC, where your ultrasound probe will detect the exact location of the lymph node, you introduce with the help of this ultrasound probe uh, the needle. With the help of this ultrasound probe, you perform the procedure same as we have discussed earlier, and you prepare smears, and it is used for cytological evaluation as well as for immunohistochemistry, molecular testing, and protein biomarkers. So this is how you can get materials. So this is the steps of FNAC procedure. You remember, first palpation and site preparation, needle insertion, aspiration and suction, release suction, withdraw needle, expel the material, and we have to prepare at least 4 to 5 smears, in which 2 to 3 smears must be air dried for MGG and GIMSA stains, and 2 to 3 smears should be alcohol fixed. So PAP stain and HE stains are used in alcohol fixed slides. Now how to prepare smear? So first is pull apart smear method that is commonly used, and it is helpful for making thin smears. Second is squash smear. Press, slide to squash and then lift off. So this is called squash smear. Third is touch imprint. Whenever you get fresh sample in histopathology, you lightly touch fresh tissue on the slide and it makes a imprint on the slide. This is called touch imprint. And crush smear. Crush the tissue you get or received and you spread with the another slide, and this is called crush smear. So these are the smear. Once you prepare all the smear, as we have discussed, there are two types of smear. One is air dried smear. The advantage is it is better for low power assessment of cell size, aggregates size differences between small and large lymphoid cells, and allows better evaluation of background elements like granular bodies, necrosis, granulomas, and blood. And in this, commonly used stains are May Grunwald Giemsa or MGG stain and Diff-Quick stain. Second is alcohol-free smears. Advantage is it is for the better assessment of cellular aggregates, superior visualization of nuclear chromatin patterns. So it is important for nuclear chromatin pattern detection. It helps distinguish small lymphocytes which is having compact chromatin, and large atypical cells will have a open chromatin. And common stains, these are pap stains and hematoxylin and eosin. Now another is cytospin preparation. So it is prepared from cell suspension submitted for flow cytometry, and usually right Giemsa stain is preferred. It is utilities for quality assurance, and it assesses cell viability, sample adequacy, predominant cell size and overall sample quality. Third is liquid based monolayer preparation. So preparation from needle rinses, and advantages are excellent cytological details are visible, uniform monolayered cell distribution is there. But limitations are also there because in these needle rinses, background elements are difficult to identify, cells appear smaller, nucleoli appear more prominent, and cell aggregates may fragment, and artificial tight lymphocyte clusters are seen. So these changes may lead to diagnostic pitfalls or misinterpretation. So this is a monolayered liquid based preparation where this reactive lymph node shows lymphohistiocytic aggregate, and it shows here these are the follicular dendritic cells, and it is having clear open chromatin pattern, and these are the lymphocytes which is showing compact chromatin pattern. So this is how this cytological preparation with its different stain showing comparative value, where MGG is better for cell size comparison and background. Limitation, it is showing less crisp nuclear details, while fixed smear, PAP and HE gives very much good details of chromatin pattern, and aggregates are well seen and less background clarity. Cytospin, it is for quality assurance as well as assess viability, and it is having a limitation related to limited architecture. Liquid base, which is excellent cytological details, but background details are not possible to detect. And after preparing and staining all these slides, you can also use the material for ancillary test if lymphoma is suspected, like flow cytometry, immunocytochemistry or molecular studies. So it is helping in B cell versus T cell classification as well as subtyping lymphoma. Microscopic clues. Now we will discuss how you judge the diagnostic clues to reach your perfect diagnosis. So low power examination, it is the most critical step. It helps in detecting whether the adequacy is sample is adequate or not, whether the smears which are prepared are lymph node origin or not, and we can also detect overall pattern with the low power examination. And we can also detect low power pattern recognition by one is cell distribution, whether it is evenly dispersed, whether aggregates are present or not, or cohesive clusters are there or not. Second thing, cell size pattern. We have to see whether the small cell are predominant or large cell predominant, and so that we can say whether it is monomorphic versus polymorphic. And if we detect very large pleomorphic cells under low power, it suggests Hodgkin's lymphoma or metastasis. So, low power microscopy is very much important. So, now let's see all the clues one by one. So, first is core criteria for adequacy. So, the sufficient cellularity, it depends on direct smears, cell block preparation, flow cytometry samples, as well as any ancillary studies. We can detect whether it is cellularity sufficient or not. And if we get samples from imaging guiding FNAC like USG, then minimum adequacy criterion is if you find more than or equal to 40 lymphoid cells per high power field in the most cellular area, and when no granulomar metastasis is seen, it is called adequate smear. And good smear quality depends on thin, evenly spread smear. If smear shows intact nuclear details, minimal crush artifact, and no excessive hemodilution, then it is called good smear quality. Second, gross examination of the smear. Generally, it is underrated but critical. We have to see when the smears are prepared and stained whether you can find a ovoid bullet shaped purple cellular area. See here, you can see this type of smear, tongue shaped smear with this feathery edge. So this is best area for morphology. And Romanovsky stain shows intensely purple due to lymphoid richness. So this type of smear is ideal smear. And suboptimal gross patterns, when there is entire slide is covered with the thick material, no feathery edge, or if blood dilution is there, or patchy or irregular smearing is there. So always examine gross morphology before microscopic evaluation whether your smears are in a good category or not. So make a practice to prepare this type of smear so that you can have easily thin smearing practice, and you can get your material properly or evenly spread on the slide so that you can do microscopy easily. Now, third step is cellularity. Normally, whenever you aspirate lymph node, it is highly cellular. Sometimes there are causes of hemodilution because of some large needle size, imaging guided procedure where the ultrasound probe may interfere with your needle to and fro movement, or sometimes target movement during aspiration, which also lead to hemodilation, and repeated passes may cause dilution. So what are the causes of now scant cellularity? If lymph nodes are having fibrosis or sclerosis, like in case of nodular sclerosis of Hodgkin's lymphoma, some large B cell lymphoma, or desmoplastic metastatic carcinoma, where already lymph node is fibrous, so you cannot get adequate amount of material. Second, acellular material replacement, like if lymph nodes show mucin, colloid or amyloid or chondromyxoid matrix. So, low cellularity in suspected lymphoma is there. So, do not call reactive blindly when you get low cellularity. So, always prefer second attempt to or go for repeat FNAC, and mostly prefer USG guided, right? Now, what are the artifacts which are the major cause of misdiagnosis? One is thick smear. If you are not preparing smear evenly spreaded or thin, then there is overlapping of nuclei, and thick smears lead to poor chromatin details and impossible size assessment. So always make thin smears. Second is crush artifact. So commonly, if the smears or material is from germinal center fragments or high grade lymphoma or small cell carcinoma metastasis, and you uh, prepare smear with very much pressure, then it lead to crush artifact. And lymphoid tangles like spider like hematoxylinophilic strands, it is due to fragile nuclear disruption, and it is seen when lymphocytes are crushed with epithelial cells in case of thyroiditis, Warthin tumor and granulomatous lymphadenitis. So here you can see this is the extensive crush artifact where you see these are the spider-like artifact where you cannot judge morphologic interpretation in this type of smear. And if minor degree of crush artifacts are there, you can say these are the elongated cells due to crush artifact, right? Third is merge cells, which are also called basket cells or Grumpet's shadow. And by definition, these are the lymphocytes showing stripped of cytoplasm, and this nuclear membrane disruption is there, and it is pale basophilic strands commonly seen in CLL and SLL, may be numerous in this type of cases. And important is occasional smudge cells can occur in benign nodes, but numerous smudge cells if seen if monotonous small lymphocytes suspect CLL or SLL. Now always look for background. So it is highly diagnostic. So after your adequacy is established, assess background. So first in background commonly seen is lymphoglandular bodies. Another name for lymphoglandular bodies are lymphoid globules, Soderstrom bodies, cytoplasmic fragments and lymphocytoid bodies. So these are the cytoplasmic fragments, similar staining to lymphocyte cytoplasm. Here you can see these are the cytoplasmic fragments showing same staining characteristic of the cytoplasm of lymphocyte. Abundant in lymphoid aspirates. 20 lymphogranular bodies per high power field strongly suggest lymphoid origin. Lymph nodes, tonsils, thymus, spleen, even ectopic lymphoglandular tissue also show these type of lymphoglandular bodies. And these are more abundant in aggressive lymphomas because fragile cells are there, but they are also seen in melanoma, small cell carcinoma, seminoma or small blue cell tumors. So, lymphogranuloma confirm lymphoid tissue presence, not necessarily lymphoma, right? So, whenever you find this type of granular bodies in your smear, it suggests lymphoid origin. Second is some background elements like powdery fine necrosis, it is in caseous necrosis, tuberculosis, coarse necrosis, either in infarction or aggressive lymphoma, fat vacuoles, if lymph nodes are showing fatty replacement, keratin debris in squamous cell carcinoma, melanin pigment, if metastasis from melanoma, amyloid, medullary carcinoma or plasma cell disorder in lymph node metastasis, colloid if thyroid carcinoma is there, mucinous adenocarcinoma, neuropil neuroblastoma and tigroid backgrounds in seminoma. So let's see all the types of background in microscopy. So here you can see this is the granular fine powdery pink acellular material. So this is called caseous necrosis. So this is abundant caseous necrosis, and these are the lymphocytes in the smear. Now here you can see these are the degenerated polymorph, and some of the polymorph are viable. So these are the necrotic cells in the necrotic background, mostly in if lymph node abscess is there. Here in this smear you can see coarse melanin black colored pigment in the background, and these are the lymphocytes in varying stages of maturation, and it is the smear from the metastatic melanoma. So this black pigment is in the background, suggesting some of the clues regarding malignant melanoma metastasis. Here in this smears you can see one is necrotic background with degenerated polymorph, but more abundant are anucleated and nucleated malignant squamous cells in the lymph node aspirate. Here also this is a PAP stain, here it is a MGG stain, right? So here you can see these are the lymphocytes and these are some malignant looking squamous cells. So this is malignant metastasis from squamous cell carcinoma in lymph node. So background is suggestive or it's giving some diagnostic clue. This is again a amyloid tumor due to amyloidosis. Here in the PAP stain, this type of amyloid clump, this is acellular pink material in HE section, but in PAP smear it is greenish in color acellular material in the lymph node aspirate, suggestive of localized amyloidosis. This is smears from the metastasis of neuroblastoma, where you can find this type of rosette in the smear, and this is called neuropil. These are the cytoplasmic fragments processes which is called neuropils, and these are the different types of rosettes you can find in the background. So these are the diagnostic clue here. Here this is called tigroid background because it is having a similar to the tiger skin, where light and dark area of and some spotted uh, appearance of the background material. So it is the seminoma metastasis to the retroperitoneal lymph node, and it is staining characteristic where the cytoplasm of these neoplastic cells. See, this is the neoplastic cell and this is the cytoplasm. Same colored background material is in the background, and it is comparable if you compare the size with the lymphocyte. So this is the lymphocyte and this is the tumor cell. So this is the metastasis, and because of this background effect, it is similar to this tiger skin appearance. It is called tigroid background. So characteristic finding in seminoma metastasis. Now 6, determining if it is truly a lymph node or not. Usually it is identifiable by the dispersed lymphoid population as well as lymphoglandular bodies, but it is difficult when pure necrosis or pure cystic aspirate is there or completely replaced by metastasis. Now, cellular aggregates, which are the critical for pattern recognition. So, normal aggregates, which are called lymphohistiocytic aggregates, showing tangible body macrophages. See, this is the tangible body macrophage. This is the nucleus of macrophage with prominent nuclei, and these are the engulfed nuclear debris and cells in the cytoplasm. So, tangible body macrophages, centrocytes, cleaved centrocytes, centoblast with prominent nucleoli. So, seen mostly these type of aggregates in the reactive node. Here, this is the low power appearance of pigmented sinus histiocytes from the endobronchial ultrasound guided transbronchial aspirate of anthracotic mediastinal lymph node. So, these are the black pigmentation you can identify in the smear, and these are the nothing but the pigmented sinus histiocytes which gives black color appearance. Abnormal aggregates in the form of granulomas, which are epithelioid histiocytes, and the pattern it is called fish in net nuclear orientation. So, this is the loose aggregate of, these are all epithelioid cells. See, these are the epithelioid cells, and these are the having fish in the net appearance because they are forming a granuloma, and mostly it is seen in the tuberculosis and sarcoidosis. Here, the poorly defined cytoplasmic border, which you can find spindle shaped and twisted nuclei and having open chromatin. So, these are the clusters or aggregates of epithelioid cells. In the granuloma, you also find fibroblast, lymphocytes along with these epithelioid cells, right? So, these are also called sleeper shaped epithelioid cells. So, this is called fish in the net nuclear orientation. Second, follicular lymphoma, in which low power pattern show nodular aggregate, then less polymorphous aggregates, and predominantly centrocytes are there in follicular lymphoma. In metastasis, you can find malignant epithelial clusters, pigmented cluster in case of melanoma, and spindle cell clusters in sarcoma. And anaplastic large cell lymphoma may show cohesion. So, here in this follicular lymphoma, in the scanner view, you can appreciate this type of nodularity in case of follicular lymphoma. And in this 10x view, you can identify uh, nodular cell aggregates. This is the case of follicular lymphoma. And in high power view, you can see this is the aggregate of the cells, which consist of cleaved centrocytes and centroblast with prominent nucleoli, and these are the dendritic cells. Now, we have to see cell size and monotony, which is the cornerstone of diagnosis. And you have to assess in thin areas, at the feathery edge, and compare with RBCs and histiocytic nuclei. So, what is large cell by definition? If nucleus is equal to or larger than histiocyte nucleus. So this is a histiocyte and this is the nucleus of histiocyte. Now, in the background of smear, you have to see or compare the cells with the nucleus of these histiocytes. Whenever you find this type of cells or this size of nucleus of the cell, it is called large cell. So this is, you can see, this is a small lymphocyte, right? And this is having a size comparable here with the histiocyte, smaller than this, but some of the cells here show comparable with this histiocytic nucleus. So this is how you can judge the size of the cells of large cells. And chromatin pattern also important, whether it is vesicular chromatin and whether you can find prominent nucleoli or not. Now in reactive node pattern, you will find predominantly small lymphocytes, occasional large lymphocytes, histiocytes, and this is called polymorphous appearance, right? So reactive nodes show polymorphous population. So this is called polymorphous lymphoid population. This is a smear from lymphoid, reactive lymphadenopathy, where you can find different sizes of cell, starting from small lymphocytes to centrocyte, large centrocyte, or small cleaved, large cleaved. This is centroblast. So you can have different sizes of lymphocytes. So this is called polymorphous lymphoid population and it is suggestive of reactive nature. Here again, this is the MGG stain or dipstick stain which will show this type of enlargement. But if you see same slide which is stained by pap stain, here you can identify clear nuclear details, right? So here this is the immunoblast, largest in the lymph node, aspiration and prominent nucleoli. And here these are the small lymphocytes, these are the centrocytes and centroblast in the smear. And you can see open chromatin, and this is lymphocytes will have a this compact chromatin pattern. So this is again two stains showing polymorphous lymphoid population. So there are abnormal patterns, like if you find monotonous small cells, it suggests low grade lymphoma. Monotonous large cells, it suggests high grade lymphoma. But very large pleomorphic cells, which shows either Hodgkin's lymphoma or metastasis, right? So what is the now diagnostic algorithm? First check adequate cellularity or not, smear quality acceptable or not, any background diagnostic clues are there or not, lymphogranuloma bodies present or absent, what are the types of aggregates, what is the predominant cell size, whether it is monomorphic or polymorphic. So only after this you proceed to lineage workup. So now to summarize today's session, accurate interpretation of lymph node FNAC depends on a systematic approach. So first, ensure proper clinical prerequisite and patient evaluation. Second, perform aspiration using correct technique. And third, prepare high quality smears and use appropriate staining method as air dried and alcohol fixed preparation. And finally and most importantly, evaluate the aspirate using pattern-based cytology assessment. Now, by identifying whether the smear is dominated by necrosis, granulomas, cellular aggregates, dispersed lymphoid cells, we can narrow the differential diagnosis and select the most appropriate ancillary investigation. So remember, good cytology begins with good sampling and good diagnosis begins with good pattern recognition. And mastering this principle will help you interpret lymph node cytology more confidently and avoid common diagnostic pitfalls. So thank you for watching. In next topic, we will discuss algorithm pattern-based approach to lymph node FNAC. And if you found this session useful, please like, share and subscribe and join our Telegram channel for more pathology teaching resources. And do not forget to comment about today's session as well as any query regarding this topic. So keep watching. Have a good day.